who's our Vice President of Medical Affairs and our lead hospitalist area, and he's the Assistant Head of Directors in the Italian Medicine, recently the whole system. So,
take your mask off so we can hear you better. These things are far.
I'm back here. So, and I'll be, and he's actually the system head now for palliative care, medicine for all of them and stuff. So we're excited about that. So we thought tonight we'll be here to answer any questions, have a nice discourse. We ask that everyone that wants to speak have that chance to speak, and that we will give the answers. You may not agree with some of the answers, or we may not know the answers tonight. But we will promise to have someone, either one of us or one of our members of our communication team, get back to you with an answer after you do this. So, with that, we leave it open and let people ask us questions.
I have a couple of questions, but I'll take my time. I've lived in the community since 1969. I was lived in Westchester, I was born in Dorchester, New York, and my dad got a job here as the principal of Lee's Home. I'm in medicine. I've been a nurse since I was 20. I started out at Vassar Hospital in the ICU and eventually 4 years later in ER nurse at Westchester Medical. I worked in many hospitals in the area. I've noticed that as hospitals have become more of a business, and I was one of the first nurses probably in the Hudson Valley to go on strike at an institution, which was Vassar. We did it twice. That business became merged with medicine, and it wasn't a good fit all the time. What I really, when I left Westchester, I noticed that I didn't understand why hospitals bankrupted institutions, but they started eating up a lot of these broken hospitals, mostly on the other side of the river, more recently in Kingston. And when I was working at Westchester, we were told these are feeder hospitals. We've got to feed the medical center. In other words, once you enter the system in that kind of institution, which was a level 1, that was a level 2 for the moment, until it's tried to become a level 1, which is hugely important that happen. It involves the money leaving Dutchess County going to Westchester, and at one time they wanted to tax us because we were using their resources. But anyway, I always thought it was a bad idea to buy a broken hospital. But they seem to have made them work. And the one thing that they've done is they've labeled every hospital or identified them and advertised them with a specialty. This is where you go. Vassar at one point was telling, we're having babies here. This is what we get. This is a champagne dinner. They really advertised expanding their unit. They wanted to become a real NICU, something that I would leave the area for, but we no longer have to leave. We, in this area, do not want to leave here to go for a higher level of care if it is possible. You can't have neurosurgery here, really, and there's some things you do have to leave for. You have to shop your hospitals like you shop a menu. So when they started buying these hospitals, I understood that it increased the viability of the core, which is the facility in Westchester, because everybody, you were always going there, and they were always funneling money into the hospital. I thought that's what Sharon was going to be, a feeder hospital, similar to Roundtable, and that it was going to really support this institution. Unfortunately, we did the census before COVID, and there should have been a census after COVID, because it's nothing like it was before COVID. I decided, I felt guilty. I walked into Sharon, remembering for the first time in 50 years, I had my tonsils out there, and it was very different now. And I said, I'm taking a lot of money, because I'm a huge consumer of the system, to New York, to White Plains. Why don't you get it right here? And I'm talking about, I've had a series of MRIs, and they're not cheap, but this hospital has an MRI machine that only certain people, I have a neurostimulator in, I can't go into any machine. I have to hunt and look around, go to Westchester to the city for what I need. I don't know how I figured it out. I pushed and I said, I really want to have an MRI down here at Vassar. I had my representatives that put your device in, look at the specs of the machine, and go, that machine is awesome. Why are you going so far? So I said, okay, I'll have my MRIs here. I'm going to shop here for that. So during the whole process of doing that, I noticed that when it came time for billing, I was very specific because I have 3 insurance. It shows up in the system like that. I didn't want them to make a mistake. And I wanted to make sure that they met the 90-day window for revenue coming back into the facility. I didn't want a mistake to be made. No matter what I did, the mistake was made. It was beyond a 90-day window, and it's 6 months later, and I'm still struggling with this problem. If billing is a problem, that only can add to loss. It's a simple, not a simple thing, but places I've noticed that can't manage billing anymore because it's very complicated, they outsource it. If you can't do it, you can't afford to lose that money. That's just one aspect in the system where if you're not getting paid in a timely fashion, and I'm just one person, like really fighting for the hospital, and it's not happening, I'm like, why? I complain to supervisors. I'm consciously trying to make an effort to use this facility. You have an excellent hand surgeon right here. What best in the world? Probably one of the best hand surgeons in the world. I fell going into a doctor's office. I tore the ligament on my thumb, trashed my shoulder, my arm is like only 90% useful. I didn't have to go to the city. I had to stuff right here in Sharon. I had the ability to look at all the hand surgeons and HSS. I knew where I was going. Somebody was here in Sharon. How did I find out about him? Through a friend. Go to this doctor. The advertising here has been horrible. I listen, I'm on the road, traveling in and out of Westchester all the time until I was working nights. I listen to K104. I listen to all the local stations to hear about Sharon Hospital. I would look for billboards advertising Sharon Hospital. I'm just not seeing anything. Advertising is you know, people that shop for where they're going to buy the best shirt we have. They shop for medicine the same way. And I think we've missed an opportunity, and I don't see why we're overlooked. That's what bothers me. I didn't know until I looked in the Millerton News that Sharon Hospital was going to be revamped when New Dance first came. And it was like a secret. And if we do that all the time, I don't know how it's going to add to viability for hospital. If nobody knows you're here, you haven't assigned us a specific thing that we can do here, plastic surgery. Come to Sharon to put those reverse shears while we recover from your body. I'd be there. I would be one of their first patients to come. But I don't know how this happened, why it happened, and I don't ever hear you talking about this hospital on radio.
I appreciate your comments and where you're coming from. Healthcare has changed. It's evolving. Healthcare has changed. Sharon is more than just the city, the town of Sharon. It's the region of 35 communities. I agree with that. In the year, there was a reason why this hospital was purchased by HealthQuest years ago, and it wasn't because it was being successful. Okay? It's gone through 4 leadership changes in 10 years before we get there. So we're in the midst. This is the 4th year. Sharon Hospital has been part of a semblance of our system here. And that, you've gone through a merger of the two large systems in Connecticut and New York to create this. So you've had a lot of turnover in regards to creating the infrastructure for an extremely large system. Regarding billing, I mean, you had, let's just go with our, as I mentioned earlier, our electronic medical record had been completely revamped. There are still physicians in our region that do not use EMRs. They use paper still. And to communicate and work all that out with a very, very rudimentary infrastructure will take a lot of time. In regards to building services, that's why we're here today. We are looking at taking a hospital, which is isolated from a lot of tertiary and second and quaternary even centers throughout the region. We're looking at trying to take the demographics of the community, take the economy of the way healthcare is being practiced today, and utilize the hospital to the strengths of what the community's needs are. Are we getting hit at all on every single one? No. But we're going to do our best to offer services, which right now, over the years before we even assumed the hospital, had deteriorated to the point where there was no services. Oncology, neurology was vacant. A lot of other services had gone down. So we are in the midst of rebuilding them. That's why we, over a year, went over very extensive planning, bringing in together members of the community are the foundation for community health. We brought in physicians on our staff itself, our physician leadership team. We brought on our board members. We brought on the system leadership, looking at strategic planning. And then we actually, after we had done all that ourselves, we actually listened to our board, we listened to the community, and we actually brought in a rural health expert consulting group to look at everything we did. And we had them do it separate from what we did, just to show that we want to hear and see if there's anything we had forgotten. And there was about 80 to 85% concordance. Everything you mentioned, we noted, because all that stuff has to be rebuilt. All that stuff has to be done. And while all this is going on, we still have to actually take care of the community. And that has led to the losses that we had shown, in our previous presentations of close to $40 million just in 3 years to handle and to do the basic services that we're trying to offer. Bringing in specialists to this area is difficult. It's more than just paying them. It's more than that, as you noted with our conversation earlier. It's difficult to find adequate affordable housing. So that's something we have to work on as a community. We want to be active members with the community development to do that. And then, they don't come single either. They come in 3s or 4s because you don't want to be on call every night. It's not like the baby boomer generation like myself, where we sacrificed and did call and we lived medicine. It doesn't work that anymore. And can a community like this support 3 neurosurgeons? No. Can it support, 5 or 6 oncologists? No. That's why, as a system, we use the benefits of the system through our plan to bring on various specialists based upon what we saw as the needs of the community, and even what our consultants saw were the needs of the community. And we then build around that, leveraging telemedicine, leveraging rotating multi-specialty clinics, and having rotating specialists come through that the system are bringing through. And even there, we're having difficulty with some recruitment efforts. And that's why in my previous position, before I took the job as president, I was a vice president on the New York side, and actually an education expert. So I helped design all of the surgery and medical residencies on the New York side of New Advance in 2017 through 2019. Knowing we can't recruit here, or have difficulty recruiting, let's grow it. And that's why family medicine, internal medicine, OBGYN, emergency medicine, general surgery, all those residencies are now coming to fruition where some are actually reaching their 3rd year, so it's recruitment time. And guess what? We're starting to be able to recruit, particularly family medicine. So we are starting to bear the fruits of everything that you're bringing up. That's the stuff we had to build, and that's where the infrastructure part of our plan comes in, because it was a very well-functioning community hospital. but it was rudimentary in regards to where do we need to go in the future if we're going to be sustainable and viable for what the community's needs are. And those are all the things we're working on right now. And it's more than just turning on a switch and getting there. It costs a lot of money. There's a lot of infrastructure put in here. And the losses we've incurred, we can't pay those bills. The system has to pay it. And just like here, we want the money reinvested in the community so we can rebuild things and add capital to build the things that we need here. And unfortunately, other communities have had to sacrifice their ability to build out their issues that they have because they're actually helping us stay viable. So that's the unsustainable model, and that's where we are today. And that's why we're trying to actually develop the various services and service lines as we have discussed to move forward in the future. So I know it's a long answer, but especially like even the MRI, that was months ago because we actually have installed a new MRI in mid-October, which actually is the best one in the system right now. So I'm very encouraged by that, by the way. So that's kudos to everybody. Finding physician services and physicians too. There's a new issue. We knew that was a problem with finding specialists in the area and finding doctors. So the system has invested in a very, very good program called KYRUS, K-Y-R-U-S. And currently, I think 400 physicians are currently on that, where you can actually look them. If you look up the specialty on our website, you will actually have a list of the doctors that are in our system that actually practice those specialties and where they're located. And then currently, about 15% of these people, currently you can directly schedule into their practices and schedule your appointments. And the goal is by the end of fiscal 2022 that we'll be able to get between 15 and 20% of all appointments that can be scheduled directly into the physician's offices and practices. So yes, that infrastructure was not here. We had to do all of that. And it takes time to rebuild and do all of those things. But it costs a lot of money. And throw COVID in the mix and everything else, it's been difficult. And that's where we are. And that's why we're here.
I didn't talk about this system. I spent hours looking for doctors within a 50-mile radius. See if we don't know.
Yeah, just go check our website. The New Advanced Health website. All that's on there.
And why aren't you doing any advertising? Like, specifically the maternity ward, like how fabulous it is? Why wouldn't you let anyone know about it?
The current list, going with our communications teams and stuff like that, our current strategy is actually utilizing digital advertising because that's what the consumers have been asking for. That's what people have been doing. And if you check, again, the website, all that's on there. And that's where we're putting a lot of the money, so on the Google searches and stuff like that, because that actually is where the people that are going to be using our services are looking for us now. So,
Yeah, I mean, the approach that New Advanced takes to marketing is the market service lines and they do it in a cyclical fashion, right? So each service line will have its marketing period. We did do, it's been a little bit now, maybe a year and a half or so, but we did do a big marketing campaign for the OB unit at Sharon. And it was focused on, we're here, we deliver, we give excellent care. It lasted for maybe 8 to 9 months. In addition to that, we do have all the services that we offer out on the website with all of the maternity units too. But as Dr. Harper mentioned, we don't do into much of the billboard marketing. I know you mentioned that. That's not the approach that we take. There is a lot of the social media marketing that you'll see.
As a follow-up to that, you kind of alluded to this, but why have you not recruited OBGYN doctors to the area who provide care in the area and then deliver babies out of Sharon Hospital?
So, again, this is when I do have the experience with that. In 2017 to 2019, we did recruit 2 OBs to this area to work with the current group in Sharon, and they did not last more than a year.
Who was? She was.
We had 2.
Wasn't Dr. Tracy?
She's
No,
still
it
here.
wasn't Dr. Christie.
Dr.
No,
They're the one that was supposed to always go check into our hospitals and so maybe in for a short term and count as being.
and one moved over to Northern Dutchess. That's because he actually felt more comfortable in that environment than here. So we did recruit 2. Then we spent an additional year actively recruiting, and we could not find anybody else. And then the local group, we actually worked in conjunction with the local group here, and underwrote actually a guaranteed contract with them for over 2 years, and they could not find anyone. So they, again, we gave them the option to say, okay, try. And we have tried every option we had, and they looked, and they could not get anyone.
It's not like Sharon and BGN just recruited one.
They recruited one.
Right, good one from NYU. So what's going to happen now when this board gets closed?
Again, the issue is not quality. The issue was never about the providers. The issue was, again, balancing there's multiple things. The finances of running the unit itself has been quite expensive. The need for all the other services necessary. We've had a very tenuous hand at having pediatrics and pediatricians covered because you have to have that group. We don't have a local pediatrician group here. We have to bring in a group from another area. And it's been difficult. We have another local pediatrician that is actually phased out of active call now. So that is an issue. We don't have practicing pediatricians even in our health system right now. So, and on top of that, keeping adequate staff in the unit itself. It's difficult to recruit to the area, let alone keep them here. So we have to pay exorbitant fees for people, for locals that come in and come through. That's why we developed our own education program, Residency in nursing. And we actually ended up hiring 5 of those nurses to help fill that. So just over the 3 years that I've been associated, 3.5 years now, here, 4 years, we've had issues with pediatrics, we've had issues with our OBGYNs, we've had issues with staffing, all of that leading to an unstable system, which has been very difficult to maintain.
And what are the difference in numbers since COVID? Since I personally know a bunch of people who moved here and had babies that showed up. And Sharon OBGYN also was hard to get appointments there because they were always, their schedule was just so booked. So like, how busy does it have to be for you to make money off it? For you
It's not making money to currently average all of those, the infrastructure that's necessary to run the unit. Even when the unit, if we have one patient a week, we have a minimum of 2 nurses on the unit at all times, just in case people come through. So by having all of that ongoing, it's to the point where we've had difficulty with the, the doctors. Can you repeat your question one more time? Sorry.
How busy is that?
Oh, we're averaging less than 3 deliveries a week.
Excuse me?
Okay.
And that's since COVID.
And even before. It's all the numbers have been relatively the same since 2019, right around between 180 and 200 census. It's all right around there.
Only since the first announcement that maternity was closing, because prior to that, there were up to 60 a year. And so to me, it seems like there was a sudden shift, right, a sudden drop between the first announcement maternity was closing and then afterwards, right? And so we lost one physician who was reading about 60 patients a year in Milford. And that position could easily been replaced for that clinic site, my understanding. And then we also had a problem with nursing, because a lot of nurses, which I completely understand, did not want to stay at a place where it was not going to have a job in the next year. And so what my presumption would be is if you had a bunch of nurses leave after that time, and you have to keep maternity open, you have to replace them with these locum nurses, right? I don't know, but with these like travel nurses, right? And those cost so much more, and that adds to the cost of maternity for the past several years, since 2018. And now that you've had the second announcement, of course, nurses once again are wanting to leave and are leaving. And so that's only going to be costing more for the hospital and for the system to replace. So I guess one of my questions is, do you think that if there had been all these announcements, those nurses would have stayed? And how much extra money do you think you spent in the last couple of years paying these traveling nurses that you had to spend?
Can I say something?
Yes, I mean, we're at the point from the time the hospital purchased to now, the stats are showing greater than 40% of the local women of childbearing age who are pregnant seek health care or seek OB care that's beyond our hospital, Charlotte Rutherford Renal Hospital, will be on the area. 40%. This is even from the time we purchased the hospital to now. And that statistic has remained relatively stable. So all imagine 40% leave the community over there. Now, it could be because we don't know and they view or anything like that. But all so to maintain services, to actually have that higher number, or to get close to, let's say, breaking even, we would actually have to double or triple our population here just to get to those births, which isn't going to occur in 1 or 2 years. And that's where our issue is.
Well, I feel like it goes back to the advertising again, right? Because I think like all three of us are of childbearing age, and we should be receiving these advertisements.
I've never heard anything. I've seen advertising for every other hospital there, but not this one, not once.
And then my kids go to school where there's many women from around, from our community, and people didn't even know that Sharon Hospital was still delivering babies since 2018. And that to me is a real tragedy. Also, I don't know the background. I came here from the city, 5 years ago, and I at first thought, of course I'm not going to deliver at Sharon Hospital. Like, why would I deliver this small in Castle? But then I talked to other women in the community, and then went and interviewed went to the hospital and saw what a great resource is here. And then decided I absolutely have to deliver my babies here. And I think that, not every woman is going to do that. And so there really should be better advertising. And not just on a typical basis, because you're going to be missing all those women that are becoming pregnant from like January through November. If you're only advertising, on a couple months at a time.
I mean, it's been an honor to work and actually be involved in building families here. And this was not something we took lightly when we came to this decision. That's one of the reasons why we even had an outside consultant come through. And they made the same recommendation based on this. If you look at the competing hospital that actually is in the local region, their number of childbirths is not much more than ours. So again, a lot of people are leaving this region and going elsewhere, and we're trying what we tried. And we're at this point now where we have to look at, based on our demographics, on the way healthcare is working today. There's a lot of other services that we have to typically offer that the community will need now and in the future that actually the hospital needs to actually offer. And we want to be here 20 years from now, 30 years from now. If we are not part of the larger health system right now, especially during COVID, this hospital would not be open. That's how difficult this has been. And this is a difficult decision. As a physician, I did not take this job to actually come here to purposely close the unit. But it was difficult, and we really had to weigh all of those options before we made this difficult choice.
Yeah, and so here, we're so grateful that you're here and the classroom here with us, that you were willing to have this conversation with us. We definitely want to keep this very cordial. So thank you for that.
That's it.
And I just going off this like you mentioned, this traveler coming in. One thing that they suggested is we have this huge community with lots of deep pockets, right? And ever since we had the Sharon Hospital rally 2 weekends ago, we've been approached by multiple people who want to donate to continuing maternity. And I am wondering, what kind of avenues do we have for that? And how much would we really be talking about?
And we are humbled that the community has really taken it for years with no philanthropy. Every year we receive the outreach that the community has offered us just in the past year. And with this, we are honored that people are offering financially and set up an endowment or something of that nature. And we'd be willing to sit down and talk to everyone about this. But I also have to then balance, we always have to balance with the alternative in that it was more than money. Yes, we mentioned finances, but if we do this is occurring in a lot of our areas right now, with our nursing units throughout either OB or other units, with the changing economic need that's out there. So all of these things come together, and that's what we have to look at when we make our decision to close. It's more than just financing. But we are willing to sit down and talk to people about that, because there's a lot there. But again, we've got to balance also that enthusiasm that there's other services who say, why don't you help sponsor us now? So you see that we got to be very careful. But we're willing to sit down.
Thank you, we would absolutely love it. And, I mean, one that I had is that if there is an endowment, then that leads to further stability, right? If staff knows that there is, money for the long term, then they may be willing to either come back if they still live in the area, or potentially.
And we're open, again, this is something where the communities that support and work for us and work with us have to come together to unify, because we are a community, we're a critical community hospital, we're not critical access. We tried that, it doesn't, there's issues with the rules that allow that. But we are a rural hospital that is in need of working with all the communities that it serves to better serve them now and work together. That's what we want to do.
Dr. Mitchell, thank you. And I'm going to switch this to the other end of the spectrum. So we talked about demographics. Can you tell me what percent are 60 plus in this 35 network of smaller communities that feed into Sharon?
We're looking at between 10 and 12% growth of 55 of them over the next 10
Right.
years.
But what's the total percentage right now? Just rough.
I used to know that number off.
I can tell you for the village of Millington of 950 people, there are approximately 3/4 of that population, if not more, over the age of 65.
Okay, so
And, yeah.
And then probably go from women of childbearing age and lower, we're looking at a 4% drop over the same time frame. Say, oh, 4%, that's less. But that number is larger.
no, I understand.
And then with that happening, that actually causes that actually more people that will be dropping off. So you can see we're actually spreading out, and more people are aging,
Yeah.
and more are leaving, not all at the same time.
Yeah, you're supporting my point. So, I mean, basically, if you want to be generous, we'll say 60% of our population is 60 plus. Okay, very
Pretty
rough,
close
very
to
rough
that,
number.
too. Yes.
So it would be also fair to say that if we're really serving the needs of our community, that we really have to think about that part of our community population. And as I look at, and I don't have to tell doctors that stroke is one of the major causes of M&M, along with cardiac issues. And so when I look at emergent care support, I have very great concern. Okay, I'm very delighted to see that you got a level 2 accreditation as a stroke center. But I will tell you, it is absolutely imperative that we replace the neurologist who retired. Not to have a neurologist on staff is inconceivable. To me, that's not standard of care. If you have somebody who has an ischemic or hemorrhagic stroke, if you just follow the patient journey, as you know, brain is time. And, I have the statistics here, which I'd like to share with the group. Every minute a stroke is untreated, the average patient loses 1.9 million neurons, 13.8 billion synapses, etc., and axonal fibers. Every hour in which treatment fails to occur, the brain loses as many neurons as it does in almost 3.6 years of normal aging. Many stroke patients, if they don't get immediate excellent care, face cognitive impairment and worse, and death. Anecdotally, I know a patient who obviously couldn't get the care at Sharon and died on the way to Danbury. So I would like to know, number one, when are we going to replace the neurologist for our preponderance of citizens here who have a real risk of stroke and a cardiac event? And number two, what are we going to do about the patient journey? Because to me, telemedicine is not the answer for a stroke patient who comes into the ER. They should be seen in an emergent situation like that by a neurologist on call. Just the time between a call to 911, the journey to Sharon Hospital, the time to be processed by whoever's on call, which is my next question to you, then get to, a CT scan, have the scan analyzed, and then get somebody on the phone to talk to whoever's on call about somebody who's having a stroke, who's already losing neurons and brain matter. To me, it's just, that's not a good solution. So I'm very aware of your extraordinary neuro care that's available at Poughkeepsie and at Vassar and also at Danbury. But by the time anybody gets to those centers, let's say if you have an aneurysm or an AVM or whatever you might have, you don't have the time. And TPA is not a one-size-fits-all. So that's one part of my question. The second part of my question is, personally having experienced this, and I don't know the name of the contract service that you use for ER doctors, but I would say it's very substandard. And my husband personally was incorrectly treated, had to go to New York, and his doctor was very upset and called the head of the ER, said, how could you possibly treat a patient like this? Happy to supply the details to you. You know, a lot of friends who've had bad experiences in the ER, but I will say the exception is the nurses who are fantastic. And I will say there are two bright lights. It's testing and nurses. And, well, what nurses go through. So just, if you don't mind, I would love to get your response.
First of all, it's going to be reversed. The team health actually supplies the ER physician for our entire system.
I know that,
So
I know.
and they're doing, they actually run our residencies too.
Well, I'll
So
tell you.
they seem to be, I'll just say that we've been happy that they've helped us out.
I have spoken, just so you know, I have spoken to doctors at some of the hospitals in the neuro space, and they are all very unhappy with your service. Now, why they're not speaking up, I don't know. But they tell me that there are better services with higher quality of doctors. Yes, they cost more.
Well, again, that's a system decision. I'm not going to that.
So you don't have any say in
This
this?
is the system.
Okay.
Okay. So
Okay.
now going to our stroke program, I mean, this is where we have to, again, being in an isolated community, relatively isolated, we have to recognize that there are trade-offs at times, particularly when you are coming in for emergent care. And this is where you think out of the box in regards to modern care that's available now that we may not be available 10 or 12 years ago. Yes, we have neurologists here for years, but again, you'd have to bring in 3 or 4 just to live in this community if you're expecting that kind of care that was offered them. That's why, as part of the neuroscience service line that we offered that we're going to grow, the system has hired multiple neurologists and neurosurgeons, and they are on call 24/7. And through telehealth, they view and they watch. They actually can diagnose interpretation. We do it for our ICU and other critically ill patients throughout our system too. And in the 1 year, we had our program together for stroke recognition, where we have to meet critical national standards of the American Heart Association and American Stroke Society. We actually have received top decile recognition for diagnosis in the ED with our ED physicians, immediate transport to the scanning, and then TPA administration when they are, after they've been evaluated by the neurologist through telemedicine. And then, based upon the severity of the stroke or the need for their care, they're either stabilized here and treated as necessary, or if they require further intervention, they are stabilized and then transported to one of the tertiary centers we have in our system.
No, I know.
And we have top decile stroke mortality and 30-day mortality or 30-day readmission rates for those 3 entities. So being in the rural area, that's better than anything that's been offered in years here based on this, because we are not going to do neurointervention for an aneurysm. We are not going to do that. We don't have the capability. We don't have the infrastructure.
What about a neurologist? How about replacing a
Again,
neurologist?
the neurologist is the same thing. That's why there will be rotating specialists in the area. Again, it's hard to bring
Wait a
people.
minute, so you will have a neurologist
We will
at the
rotate.
hospital?
They're starting, this is how we start with our plan that we have. We leverage the specialists we have in our system now through telemedicine and through consultation. Eventually, we will have a critical end or number throughout of all our specialists, oncologists, neurologists, neurosurgeons, cardiovascular, and other specialties that we have there. And they will rotate in a multi-specialty nature coming through clinics. We'll initially take clinics that will start in our hospitals, and then we'll start doing outreach programs in the various communities as we grow. But that's the ultimate plan, is to have rotating multi-specialty face-to-face clinics. Once we have the critical number of specialists in our system that can handle the volumes that are regulated through the Southern Hospital
But
system.
we've had a neurologist, why can't we replace at least one neurologist?
Because they come in more than one, they can come in 3s or 4s. That's the issue.
Explain that to me, I'm sorry, I'm not clear.
It's not like the days when we all went into practice, or I went into practice, where the one specialist will stay here, live forever, and take call 365 days a year. They want, the generation of people that are now working as physicians is totally different than before. They want to do one call in 7 or 8. They want their time off. They want quality of life. They'll take less salary. That's the difference now. And that's why they have one person here actually putting my eggs in that one basket causes trouble. That's not the
Why is there trouble? I don't understand.
that's not the current standard of care. It's multiple
So
specialists.
no neurologist, you're saying, is standard of care?
So we have
We do.
neurologists.
No, see, I don't,
We
hold
have
on.
neurologists on our staff.
No, but a neurologist who is at Sharon Hospital, so if I have a neurological issue, or if I have a stroke, that neurologist can be on call and come and see me in the ER.
What if he's out on vacation?
And he has a covering neurologist
There is no.
from your new boss, from your
Then
new
how are
boss.
they going to stay in the hotel, or where do they stay? If they're
That's,
gonna be out here.
that's something we have to
That's-
state
And
about.
you see that's the dilemma. That's why you use telemedicine, telehealth now.
Okay, so this is,
Go ahead.
this is your minute.
I just wanted to check, because I take care
He
of
does this.
many patients with strokes that come through
Yeah.
the hospital.
Yeah,
So first, I would say that we loved having a neurologist in-house.
yeah.
It's a great thing. We miss having that. But he wasn't attending patients who came to the ED with strokes. If they came to the ED, even for the past decade or more, we were using telemedicine, initially from the Yale Stroke Service, and then another service. We have a monitor, computer set up, and there's a protocol that occurs where the nurse and the physician on the computer camera examine the patient collaboratively and make decisions based on that. They have access to the imaging results and all of that. When we had a neurologist here, he didn't do that. He would see them the next day when they were admitted.
I understand.
Yeah.
I understand.
And that was great. If you know a neurologist that wants to move to this area, please send him my way.
Well,
But
yeah.
let me go on. So our plan is to continue, in the telemedicine, teleneurology, and hope and invite our neurologists in our system to continue in that process, and hopefully in the not too distant future, we're going to be rotating subspecialist physicians, including neurologists, through Sharon. And that will allow us to involve an on-call system and have some face-to-face visits in the hospitals.
Right, so when do you imagine that rotation could start?
I don't know.
I mean, we're
Hopefully,
starting now.
Yeah, hopefully soon.
We've started with I'll just start with our primary care, our FQHC.
Let's talk neurology, okay?
Sure, but we have to start in one area, which was getting our primary care.
No, look, you have a lot of problems, I know, and I have even gotten to primary care, and I feel your pain, okay? But let's talk about neurology, just like you get your technical, you're here. So I'm heartened, thank you, doctor, comment that we would have rotation. Okay, so let's say a neurologist we know is going to be in situ on Wednesdays. So if I have neurological issues, I know that I can make an appointment on Wednesday to see somebody who might be from Bass or Poughkeepsie or whatever. Okay, super. When can that happen? Because I talked to, just to give you my background, I helped to do the business plan for the Wild Cornell Brain and Spine Center in New York City. I worked for 10 years with the chief of neurosurgery. So I'm not speaking from a position of, lack of knowledge. And I am very interested in the brain for obvious reasons. And I'm very worried because I know a little more than the average person, and I know you can appreciate that. In my social circles, everybody has their head in the sand when they get educated, say, oh my God, I can't go to New York and see my neurologist. I'm stuck. What am I going to do? And I say, this is our situation. I'd love to be able to tell my friends and people that I talk to about these issues that I have some heartening news, that there will be rotation starting when. That is going to allay a lot of fears. Okay, yes, we're all upset that we don't have enough PCPs. That is a very big challenge, I agree. But I really think that that's a very important message to get out, particularly to this community where there's such a skew, heavy skew towards 60 plus, and to your point, Dr. Herco, that's going to continue to grow. And if we talk about serving the needs of the community, as a neurosurgeon I know said, hey, the heart's just a pump. Okay, I can fix that. The brain, I can't, I can take out a lesion, but you can't really fix a brain. It's really a much more complex situation.
Absolutely.
So I would love your thoughts on time.
Yeah, I don't have the answer for you tonight. I know that we all want the same thing. I would be happy to get back to you when I had some more information.
Great. I would love that.
I will tell you that what we do now is, we do those tele-stroke consultations. We also do tele-neurology consultations where patients are not having an acute stroke. And then at the time of discharge, they will follow up with either a stroke neurologist or general neurologist within our system,
right,
but not in Sharon.
I know.
Yes, ma'am.
Okay, so I was Sharon Hospital for 25 years. We never had a neurologist that was on the case all the time. And we had people out here, but recently, in the last few years, it's been great. This telethon, it's been fantastic because I've been involved with it. I've seen as a nurse that we've seen patients get out of there fast. They already have all the information before any doctor from home could have made it in. It's absolutely fantastic. We've saved lives. We've seen people turn around, and people who could talk are now walking and doing everything else and eating and doing all these things that they couldn't do a few hours before that. Maybe TPA isn't the be-all end-all, but there are things that we do there. I don't do them any longer, but that's one thing that I can't say would have been any different because Dr. Finkelstein was not there. He was home. He would have to come from his house. There was nobody in the hospital for the last 25 years. That was a neurologist that was on duty. So what this does is save so much time. We get people out when we have to really quick. Like I said, they have all the numbers. They see all the pictures. And I didn't know how this was going to work with this. Oh, the patient's going to be there, the doctor's going to be here. It's wonderful. They can see, they can zoom in on everything. They can see all the movements the patient makes. And I don't think if we have a neurologist in the neighborhood, it is good. We need somebody who can follow up. But I don't think he's going to be the be-all, for getting people out safely. We've kept the ones we could keep, and we've made them better.
Actually, you actually brought up the fine point that we wanted to show this for our hospital. What is Sharon really good at? Sharon, over the years, has a great reputation within our health system in the region at having all commerce something that we should care for, we care for them. And if we can't, we stabilize them and transfer them within our system if possible to the tertiary centers that can do that. And then the people come back and then they have the services that we can offer, such as follow-up labs, follow-up appointments, the telemedicine appointments, and rehab. And that's what we're good at. We do that in our system the most of anybody, close to 300 times a year. And it works very, very well. And actually, that shows how well we're integrating. And if people are asking, well, what has worked since we joined the system? This is the one thing that really works well. And it's showing that. We don't have vascular surgeons to handle ruptured aneurysms. We don't have thoracics. No, but I'm talking about even brain stuff. But we don't have thoracic surgeons. But you know what? We've been really good at stabilizing people and having them go out. And that's the part that we have to foster and move forward as we add our other services to the area, to issues of the oncologists and on an ambulatory basis. Cardiologists, we're very strong in cardiology. And we're adding more testing capability here. Neurology with their MRI. That's why we added the big MRI machine to work on that and actually develop cardiac testing too. So we have a lot of other specialties that we're going to be growing over the next few years. But we have to start somewhere. And that's where the focus has been put on. So
You know, it's interesting you say cardiology. Nobody knows you have great cardiology testing in the hospital. And again, it's about awareness. There's no advertising.
yes. So I'll go ahead and I'll go ahead. I'll go there first. And then I'll start.
Position when I work in New York. But I've been living up here for a long time, and so I have the ability to at least anecdotally talk to an awful lot of people. The one advantage is hospital management is rotation. And the fact that you do have an older population, the major set of young people that like Sharon, don't like Sharon, is that they have acute neurologic, acute vascular, or traumatic issues. They can come here faster than anywhere else. Right? You do not advertise. All right? I live in New York where Cornell, Columbia, NYU, Sinai are at each other's throats trying to keep up with your populations. Right? You are inundated and with some huge institutions, huge financial backing, but you don't advertise at all. You have metrics that I was listening incidentally. You have metrics of excellence in this, that, and the other thing. Your population, they don't have that. You're not telling them about it. You're not telling them why they should come here. The idea that somebody is going to be able to find online, you have a 65-year-old population. How many of those people know how to get online in the first place? Let alone they're going to know how to search and then find out what's online anyway that tells them all of these metrics that they need to be hearing. You know, I don't know how you go about establishing the kind of money and influence that we need to really successfully advertise, but honestly, you're not doing anything. I mean, the notion that you're getting online and that somehow or other convincing people that this is where they should come, it's not that. I'm a little surprised about something else for what it's worth. Is you're telling me after COVID, you have flatline, but you had a massive influx of people. I mean, why is it, have you actually stopped and thought about why is it that you have all of these people, most of them fairly sophisticated people, they were coming from New York or Boston, wherever you're coming from, and yet you have not seen any kind of incremental increase in the volume of people willing to come here. I would argue they are not.
Our ED actually has shown an influx. We bottomed out, but it's only certain subspecialties have shown flatline. Everything else is starting to climb.
Yeah, but this is the point, an essential point. When you go back into New York and you listen to the advertising, right? You're not advertising we're the ones who will come here. You're advertising this because you have the best of the surgeons in the world. We have the best. They're focusing on what is elements of excellence. If you have matters of excellence or statistics or metrics of excellence, you need to get that out. And to the extent that you do, by the way, especially in most of the areas, the secondary benefit is if people know that they can rely on this place for those things, then their inclination to come for other services will increase. You got a definite revamp phenomenon.
Understood.
So the money spent or the effort spent to try to really make this place shine instead of just surviving. That's the act to it. How is it this place is surviving? Why do we want to go to a place that's surviving? And it shouldn't be in that position.
Understood. No, and I actually, thank you. I appreciate the comments because we're so proud of our staff and that we received, the CMS 5-star award 2 years ago now.
Where is that?
So,
Yeah, we find out, how do you know that?
and we will point taken on the issues in regards to that to the
I'd like to say, I have maybe 2 emergencies, not like for any emergencies, but being married to a New York physician. We had known the quality you're saying you have here, we would have come here. Instead, we got in the car, we drove straight to New York each time. And we repeatedly went back to New York to follow us. Because we were told, because nobody knew the quality was any good.
Yeah.
That's ridiculous, why you have to see here.
And actually, Dr. Marshall, we had a meeting yesterday going over our quality. You can explain our quality scores.
Yeah,
Literally.
absolutely, top decile.
But nobody knows that, it's not, we don't know it.
Can you just ask me, I just want to ask, where should we be?
Yes. Where should we mark?
I'm not marketing, I can imagine that the money spent to get marketing expert in here, sit down and go through a plan, given all the regional availability and assets and avenues for which you disseminate all of this. It would be something that would be worth your while to spend that much money, whatever it would cost, and then have a real plan about how to sell. What are the real features that you have that can sell? What are the ones that what would be best played out? I mean, I don't expect you guys to get television advertisements or newspapers. I mean, there are all kinds of forums that presumably would be getting the message out that would be very carefully calibrated to your needs, to your strengths, to a community that would love to hear all this.
Thank you for comments. I appreciate the comments for that because we wanted to really connect with you. So thank you.
Billboards is great, television is great, Northwell Health is on channel 12 news. You've got to chase your competitor because you want my business. The other thing I have to say is women here, I think if you look at this as women's health rather than just babies, that's another center of excellence. That's what you can do, women's health. I'll give you a compliment. I was on the receiving end. I was at the transition nurse at Westchester Medical when you were sending us patients, neuro patients. You did a good job. And it's more complicated than people realize. There's the care flow sheets and everything. But most of the world now is using this television because they're in this situation, but 100 times worse. And so it all, as far as nursing goes, you are in a national competition. My peers now no longer want to be nurses. They're leaving the profession at an alarming rate. We had a nursing shortage to begin with, and if you think this town is the money, like yesterday, in my mailbox, I got an offer, come for 5 days for $78,000. That's what we're up against now.
There's another thought, a very simple thought that you can do right off the top. NYU does this, virtually every hospital in New York does it, and advertises it. Are you measuring the metrics of the patient feelings that have come through here? I mean, do you have a high standard of patients telling you did a great job in residence? Do you have those metrics?
Yes. They're called HCAP scores, and we get graded on that because pretty soon we will be paid on that. And I'll just say that the entire country, everybody was doing relatively well, and then went in the second wave of COVID hit, and then everybody lost staff, everything tanked because wait times went up, all the things that we always fought against happened because everybody ran out of staff. Almost 20% of all healthcare workers in the United States at hospitals quit. That's the stat right now. And we have an area, we have sourcing people, we have some other lead nurses. We have a sourcing company that actually told us last week that they have responsibility to source 1,100 nurses right now, and they only have 58 candidates. And our health system, with 12,400 employees, we've had close to 30% turnover this year. This is our system. And currently we have close to 1,700 job openings. And we just can't find anybody. When you have temporary workers for 13 weeks making double what a physician makes right now, $220 to $230 an hour is what the sourcing companies are asking for. That is an unsustainable model. And that's what we're fighting against right now. And that's why we're going with other
nurses?
We do.
Really?
We have nurse residency programs and nurse fellowship
I
programs.
applied for a job, and I've been a nurse for 4 years. I walked out the last month of finishing my bachelor's. I didn't have any value to me. But they decided to take the whole system to BSN only. I'm better than any regular bachelor's, master's nurse. I was trained to a higher degree. No job for me. So I'm trying to figure out, what are you really doing? What are you really, I saw 30 job listings in my mailbox for a good dance this morning. Every day, 30, 40, 50. What are you really doing to recruit these people to say, I took a 12-week assignment and it turned into a year assignment. How can you keep some of these people here to get them to go on staff?
We've successfully hired travel nurses in the past. Right now, the market is insanely competitive. I don't think we would have any shot at keeping a travel nurse only because their rates that they're making are very, very high, and we can't compete. But things that we've mentioned, like the nurse residency programs, nurse fellowship programs, what these are it allows nurses that historically wouldn't have been able to go into a specialty area right out of school, or even a nurse with med surg to go into a specialty area. We have these well-developed programs where it's over a long period of time with a mix of classroom and live competency, skill-based training. And we also, now that we're part of the system, have the ability to have our nurses that see lower volume of patients here go to some of our larger institutions to train. So it's something new that we've been offering over the last couple of years, and it just continues to grow. But that's one of those things. You mentioned that some hospitals don't take nurses with associate degrees.
Your hospital, I showed my resume, I get hits on it constantly. Not that I want to go back because I'm a level 1 nurse at this point, but I get frustrated at community-based nursing. But the thing is that I think there are pools of resources, simple things we're overlooking. Dutchess Community College had such a high standard for creating nurses very rapidly. Barack Obama in his last administration had a wonderful idea. We got to get nurses out. We've got to get them out. Associate degrees, best bargain for 2 years. They're good, but it's like that's a pool that's being overlooked. You can't afford to leave anything on the table at this point. Even a billboard for advertisement. A billboard. Do you realize this is a terrible thing to compare you with? More people knew where all the cannabis spots were in Millerton because they were advertising on the billboards on Route 22. I never saw them. I'm like, are you kidding me? Sure enough, from Foley to Millerton, go to Massachusetts State Cannabis. So now we have a situation, a simple tool. I'm in my car 2 hours a day, one way. I'm going to read billboards, and if I see there's a billboard about Sharon Hospital, you can't afford to not advertise in every niche. That's what the point of this really is. And you can't rely solely on, what is this, electronics. Yeah, that's a good addition too, but I don't hear you on the local stations. I see Northwell Health. Why aren't you competitive? Why am I not hearing about the new band system and what it offers? And this is what we're trying to tell you.
Even if he has a village movie house.
Right.
It's every week, nothing about Sharon.
That's why we're listening to your Jeff offer, and we'll make sure our communications team does that.
You might also consider outreach to journalists. Have profiles of physicians who have here, who are working here, what their backgrounds are, just as kind of interviews. I don't know that the local papers would follow that, but why not try?
Sure. And we actually weekly or bi-weekly go on Robinhood Radio, and have our specialists. I go on the radio, and we try to go updates with them all the time. So they've been very accommodating. So.
When you read the Salisbury paper, though, usually the thing is the Salisbury paper or whatever, and it's front page, right? There's no counterbalance, and I don't know that you'd be able to, but again, I think virtually every avenue, every strength that you have to make your community aware, and you should be honing every strength you have.
That's okay. I want to go. So I can never come back.
Dr. Hertel, I've been reading the some of the presentations going back now when you first started when the hospital revealed the plan. I've seen the consultant's report, and frankly, I'm puzzled. I'm puzzled because this appears to be, at its heart, a money issue, a financial issue. You're claiming that Sharon Hospital lost $40+ million in the last 3 years. So one of the things that I do, I have a background, as you might know, in forensic accounting. And so I went back and I looked at the reports that are generated by the hospital in this reporting to the state, OHS. And I couldn't find $40 million. What I came up with was slightly below $12 million in the last 3 years. I looked at the auditing reports from year 1 for the last fiscal year. I looked at the financials for the prior 2 years beyond that. I didn't see it. I saw a consultant's report which claimed $40 million, but it wasn't documented. I saw they came in with $13+ million loss for 19. That's not what your financials show. There's maybe some sort of Chinese accounting that these accountants are doing, but numbers don't lie. And frankly, I'm puzzled. You know, it seems to me if you're making a monetary issue and you're saying, we lost this money and we've got to take steps to correct it. They have unutilized resources, unutilized assets. We're not getting the throughput in maternity. So you want to look at it, you want to look at the ICU, you want to look at the ER, you want to look at other places, you want to make structural changes. I know you're already measuring the maternity room and trying to figure out what you're going to do with that. So I'm puzzled. And frankly, I'm annoyed. Because if you were losing this type of money, we would see it. Because numbers don't lie. And these reports that you're making to the state are right there. So that's one issue that I really think that you have to really confront. And because it's a puzzle that the community doesn't understand. The other thing is that most people don't understand this. When HealthQuest got into this, your predecessor company, they bought this hospital basically for $3 million. It had a book value of around $25 million. $25 million of assets. You got it cheap. The reason you got it cheap was, as you pointed out in your certificate of need and in your testimony, not your testimony, but the testimony of your predecessors, this was a distressed situation. And you were going to do something about it. You were going to hire a number of primary care physicians, other specialists. That was in your documents to OHS. Which you haven't done. We track it. You haven't done it. Now, you may argue that things happen, and I'm sure you will. And I respect that. I'd be curious in your reasoning why and your explanation. But you haven't followed through. The projections you gave at the time, and mind you, they were done by HealthQuest, which was the predecessor company, but basically, it was basically with the exception of the 3 top executives, Friedberg and his 2 associates, basically the staff of the hospital of Poughkeepsie, and the whole New Man's operation is basically intact. Many of the senior people just carried right on. So the question that I have for you is, how can we believe these numbers in the case you're making if it's not supported by reality?
Well, I go to the financial part with you, in that every year we have to actually, do our annual report. As a forensic financial person, we wouldn't understand you don't do that, especially as an auditor. And so every year we have everything audited. Okay? Each hospital and our system goes through the year-end audit. On top of that audit, so we internally have an audit, then we have an external audit to perform because we have bond ratings that have to be every year. So we look at our bond ratings. to us actually having our presentation in September, when we were looking at what should our plans be, and we were looking at different models of what are the options for our hospital and our health system, and before Stroudsburg, we ended up with internal audits every year from the time that Health Trust had purchased the hospital, and then New Vance, the new company took over, which is the Connecticut side, not the New York side. So it's a different thing, so I'll go with that. Second, we actually then restated our issues during the time of the merger with two outside audit firms to restate 18 and 19, and they actually corroborated the data. Then we had Stroudsburg come in using a different accounting technique, different than what we have, and they came in, on. So essentially, we've had 3 internal audits, 2 external audits, and another company come in, and all the numbers are all the same. So that's the part that I'll say, because I'm not a financial expert, but that's literally where we are today, and that's what's being reported out there. So that's my answer for the first part of the question.
I would say, Dr. Hertel, I understand the process, but the numbers that I got, that anyone can get, by the way, this is not a mystery, is you go to the state site, and they'd be only too happy to walk you through. That's not the numbers that you sent to the state board that E&Y ordered. I have a copy of one of the sheets out of their audited report. And I'm going to tell you, if you want a problem, last year, what this shows is Sharon Hospital. Sharon Hospital lost $5.8 million. But if you really want a problem hospital, look at Putnam. It lost $13.2 million. And I understand that's one of the hospitals that you are partially responsible for, that you're the administrator of. I mean, that's the hospital that you should be looking at, not Sharon Hospital. Putnam has major issues. Now, I haven't focused on Putnam Hospital, but just reading the numbers, and numbers don't lie. So, to me, I understand what you're saying about these numbers and the audits and so forth, but these are the numbers. So, how can the consultant come up with a different set of numbers? How can a new Vance tell us that this is what the situation is? We have a horrible financial problem. We've got to raise money. We've got to close down operations. We've got to restructure. But the evidence isn't here.
My only answer is outside audits actually then looked at all of this, agree with the numbers, and have actually given us the bond rating and let us know what the bond ratings are, which were not as dropped from the bond rating. So obviously the numbers were good. I do not have all the details for the numbers that you're alluding to, but let's stop with there. Let's go to the other question. I think you're going over just that second part of that. Another question that you brought to me.
Well, I think the point is, look, I don't expect you to have these numbers at your fingertips. This is not an accusatory type of situation. You understand that. But I think it would be helpful to have some of us who are quite numerate and have the background to sit down with your CFO and or Stroudsburg and go through this documentation so that we can represent the community when we talk to them. We had a big rally. I told the community group, I said, these numbers are not correct. And I think it would be useful to establish a benchmark as to what set of numbers they really are, and why did you come up with these sets of numbers? And so I think we should get together with some of the financial people, sit down with them so that we can understand what the extent of the financial problem is. Because this is a financial problem. Otherwise, you wouldn't be doing anything about it. Correct?
Correct. And that's why I'll bring it up with our the people in our health system. But just reiterate that obviously the outside audits were good to allow us to actually fill bonds and just keep our rating. So that's the issue that obviously the numbers must be correct, or we wouldn't be here today. We didn't have a hospital.
Dr. Hertel, the numbers were correct until you had a restate going back because of Medicare fraud. And that was obviously one of the reasons why Freeberg was let go and some of his associates.
I don't want to sit there and have any accusations here.
Well,
Let's just move
I'm
forward
just
with-
explaining what the facts are, as we see them sitting on the outside. We know this, we know there was Medicare fraud that was admitted to. You signed a consent decree. You also signed a corporate integrity agreement with the federal government, that they would be looking at you for the next 5 years after you signed off on that. We know this is a matter of public record. So I think we ought to have a dialogue with some of the financial people, clear this up, and figure out exactly what is the scope of the financial issue that they have. Are they correctly interpreting it and representing the issue correctly? That's all we're asking.
I'll bring that up and I'll just state that, you know, let's keep it that they've already been stated multiple times. I will bring it up with the people that I work with to see what is something that's feasible that we could do.
We'd appreciate that.
And you know, I've been straight up and obviously discussed
I
that.
understand, and I respect what you're trying to do to make this a much better hospital.
Understood. Yes.
Not to belabor the maternity issue, no pun intended, but where are these people going to go? They have to travel at least an hour to go to anywhere but Charlotte Hungerford. Is Charlotte and Hungerford going to take at least 200 more people a year into their maternity? I mean, they're the only ones that are close. And the issue with New Van Fest or whatever it is, you want us to all go to Poughkeepsie or one of the doctors out in Poughkeepsie. I grew up here, not here, I grew up in Jersey, where you did know your doctors way back then. I moved up here in 1972 and have never had to travel more than 10 minutes to my PCP. Now, all the PCPs here are getting older. The maternity, we have an influx of people that will be coming. Kent is going to be building. Lakeland's going to be building. Amenia is building. These people, I have a neighbor next door had a baby here this past year. It's 6 months old. And I have 3 new families that moved into my area. And I live in a small community in Sharon, a lake community. And I see people moving in who are going to have children. So they're out there. They're going to be building, and those people are going to come. And then what are you going to do? Because they're going to say, well, where's my babies? Oh, well, I don't think I'll move here. I got to travel an hour. I got to travel 45 minutes. And leave. So, I mean, is that what we're expecting those people to all go somewhere else so far away from them?
Currently, our hospital, the way we have it set up.
We are really in the middle of everything.
Since we do not have a neonatal intensive care unit, any birth or any pregnancy that's considered more than just routine pregnancy is already seen by maternal care medicine and sent out to the other feeder hospitals.
I know,
So
we
we've
send
been-
babies out a lot.
So we've been working.
That doesn't mean.
So we have met with also the Charlotte Hungerford, we have met with all the hospitals in our health system to actually have prepared if and when, or excuse me, we plan on closing the unit, 8 to 10 months from the time we made our announcement in September. So, and this is modeled after what's occurred in multiple other rural hospitals in the United States. Is currently only about 30% of all rural hospitals in the U.S. have functioning labor and delivery units today. And they're dropping at about 18% per year. So it's a large number. So local hospital that did it within the last 4 years, Columbia Memorial Hospital, just on the other side of the border. They gave that notice, had a tertiary hospital, multiple hospitals ready. To this day, no emergency births have occurred in that hospital because they planned and communicated it correctly. Messina Hospital, Long Island, another area, same thing, isolated from everybody else, gave 10 months notice, same issue, no emergency births from this day on, from that occurred up to today. New Milford, same thing in our own system. So by proper communication, coordination with the other hospitals, and discussion with all the other specialists in the other hospitals and work as a team, because the patients are the priority, that you actually can avoid the majority of the slip-ups that can occur. Now, you can't account for everything. You have topics and people that are traveling through. But that's the whole goal, and that's why we're communicating that now. And that's the plan that we're working on at this present time.
But the issue stands as, Litchfield County is building. We're getting bigger. We're not like West Virginia, coal miner town. eventually, people are gonna say, I'm not gonna come here because there's no hospital, so I can take the tap on it. It's not make the difference.
But unfortunately, Litchfield County.
I have no stake in it.
Yeah.
You know, I'm not.
But I think if we quote it right, Litchfield County is the largest drop in population in related census.
But, pandemic, everybody wants to be.
We do have 5 more minutes left of the session, so
It's quick. 5 years ago, not even 5 years ago, 3 years ago, when the whole merger took place, and there was an agreement that the OBGYN would be kept for 5 years, functioning. And we're not there yet. So there has been no certificate of need requesting that there be a change. And yet, what is happening with nurses leaving, and you're saying it's not safe, you are forcing the issue, it seems to me, and we still have time to run out this clock. So we want to work on it too.
I understand.
Work with you.
I'll let you know, we never said this was a safety issue. We've never said that. We've never brought that up. Again, that's something that we actually had the outside review through the American College of Obstetrics and Gynecology. We have good quality. We maintain that. We have not stated that as a safety issue. Regarding the certificate of need, the certificate of need that was filed 3 years ago and agreed upon on the merger was that we would maintain active services at the time of the merger for 5 years, as long as they were commercially reasonable. Commercially reasonable. That is the clause, and that's where we have our issue there. Now, regarding this current, and actually December 14th is the community forum for that certificate of need that we biannually have to report on. And we actually have an outside auditor that the state assigned us that actually audits everything that we do to make sure we're compliant with those terms of that certificate of need. And we will be reporting on that December 14th. Now, this current issue that we're dealing with now, by state law, we have to actually notify the community and give them 3 days, 3 days notice, 3 consecutive days, and which was done in the local newspaper. We gave that recently, a few weeks ago. Then we have, I think it's 6 weeks or 9 weeks to report and actually file the CON after that. Since we did the CON agreement 3 years ago, and the process now is markedly different, markedly revised, and there's additional steps that have to be done. So that all of this has changed just since the 3 years where the last agreement occurred, and there's different OHS at this point compared to the one that was there just 3 years ago, or even a year ago. There's one that was complete turnover of that group. So there's a lot of change that's occurred, and we're in the midst of getting all of that information and compiling the information that the state has asked for us, and then we'll submit that CON in concordance with the way the law is set up for that, and that's where we're going. So a lot has changed from even the last time, and we're complying with that all the way through, and it actually will do more steps. So.
I have one last question. I'm sorry we didn't get the PCP improvement because that's so critical. Can you just tell us quickly what you're doing to try to solve that problem?
So we started the F2HC relationship with Torrington, federally qualified health system, our clinic, as it was initiated, and just starting last week, the mobile medical unit actually has been parked in our hospital, and they'll start seeing patients 2 days a week in our facility. And then we allow them access to our EMR, which actually helps. We allow them to do testing and imaging in our facility too. The ultimate plan is to actually have them actually open up a clinic within our hospital while they're waiting for their formal building to be completed in the next 18 to 20 months in North Kingdom. In the interim, they actually have what we call the HPSA, the Health Professional Shortage Area Designation, which allows foreign medical graduates, which are in a lot of the primary care residencies in the United States, to actually forego the need to, after their training visa is completed, that they actually by law have to go back to their original country for 6 to 12 months. Then they're allowed to come back in under a work visa. By having the HPSA designation, that allows them to forego that and allows So we're very encouraged, and we work and partner with them to actually help recruit. In the meantime, we brought on 2 nurse practitioners just in the last few months that will be starting in our 2 local practices. And 2 of the 8 graduates from the primary care family medicine residency on the New York side actually have signed on to work in our health system. We have a 3rd that is an earmark we hope to come in our region here. So just in the last 4 months, those are the things that we have ongoing. This is still going to be a tussle because we have a lot more recruitment that needs to be done. But we are encouraged that the fruits that we had planted many years ago with the residencies, the relationship with the FQHC, et cetera, are now bearing those fruits, or actually those trees are bearing the fruits to allow us to expand services. It's going to take a while because in my experience, I grew up in Ohio and I trained in Ohio and in Illinois. Usually you have to recruit 2 or 3 and sign 2 or 3 to keep 1 or 2 10 years later. So you're going to constantly be cycling people to actually find the perfect match. That's why we're working with our board, with our local community, et cetera, to work on recruitment, to work on adequate, affordable housing, which is
On affordable housing, why aren't we raising money in the community for great PCPs and giving them a package and putting a price tag on? I would be happy to go out to my friends and say, this is what it takes to bring a great PCP in our community. Everybody wants to live here. We live in paradise here. We are missing top medical care. So if you could tell me what that cost is, I will gladly help you.
we'll work with our, we'll have our people follow up with you with our leadership for the people that are doing that recruiting, working with our board members that have that standing work group right now. That's something that we work with. So,
yeah, who's the contact Dr. Herco for that PCP group?
No, that's all. I'll let Marina follow up with you.
Okay, great.
Find out who are the people that are on that work group right now.
We had a great medical doctor that came from the city to live here in the country, in this beautiful area, and he didn't have to be bribed. I'm sure they paid him. But he's living in a beautiful area. He hasn't left. He's been here for 20 years.
And we're appreciative of that. We
And
do a lot more of that.
we can get them. We just have to show them what it's like.
Yeah,
And that's what we're doing. We're
Yeah.
going through that.
Where the obstacles are.
And which of the 2 doctor's offices?
So we have our Middleton office and our,
Oh, that's-
in our local office right there.
The doctor will be getting someone.
We're trying.
Okay.
So, any other questions, concerns, comments?
So what will it take for the community? Can the community do anything to support the stabilization of the situation in the hospital? Other than, look, everybody has a community for affordable housing. Every community has its problem. I've been working on it for 15 years, going nowhere. There's nothing here to rent. That's a problem that's been identified. I don't know how we're going to correct that. What else as a community can we do to save this hospital?
No, again, we don't need to save Sharon Hospital. And I'm going to steal this from one of our board members who brought up today. We need to celebrate Sharon Hospital. Sharon Hospital has a lot of positives to it. We need the community to work with us to support the physicians we bring in the area, the services that are in the area, the services that the hospital offers. We have a lot of rebuilding that we do within the facility itself, let alone the community. And that's where we want to work with the community and work with everyone here. And because there is a larger need across the board other than one service, and all the services need to be done. And we have to work together and work as a team. And this is the reason why we're here today, to keep this dialogue going, because we have a long way to go to get this going. I'm encouraged by the enthusiasm and the passion that we see here. And it's just something that we need to keep building on. That's what we'd like to do. And that's our promise.